Good morning, everyone, and welcome to Friday Chalk Talk. My name is Maureen, and I am here with Marty, and we will be co-hosts today. Dr. Gina Piscatello is an assistant professor of palliative medicine, hospital medicine, and an ethics consultant at Rush University Medical Center. Her research interests involve patient, family, and clinician communication, ethics education for medical trainees, health equity, and allocation of scarce medical resources. Our topic today is slow codes in situations of medical futility, based on Gina's recent publication in the Journal of Pain and Symptom Management from August of 2021. For the format today, we've agreed to discuss 6 topics, and then we will have a few minutes at the end for open discussion. This is a complex topic, and today we will only have time to touch on a handful of points. We hope you take this conversation back with you to your teams. Thank you, Gina, for being here. And I'll hand it over to Marty for the first 2 questions.
All right, good morning. So our first topic kind of touches on healthcare systems. And so whether you agree with it or not, slow codes are a reality of the healthcare system. And it's impacted by system level challenges, like how much time do we have for communication? Is there the absence or presence of a hospital futility policy? How much are physicians supported by their organization, supported to set limits? And so when I think back to some of the slow codes I've been involved with, I really found it familiar at the lack of control that clinicians expressed in your study, Gina, that even though 76% agreed that physicians should not have to offer CPR, a majority still felt that when the rubber hit the road, there was an obligation to offer CPR if family asked for it. So our question for you today here is, what do you really see as some of or one of the biggest system level barriers, and what can we try to do to make slow codes less common?
Yes, I think the biggest system barrier is that we have full code as the default, and we've removed clinical judgment from the physician so that they're not allowed to choose in their medical judgment, will a code actually help a patient? Or is there like truly no potential help for the patient with the code? CPR, from my viewpoint, as well as others, it is a medical procedure. Are we fully giving informed consent for every patient that we are, choosing to have full code in the hospital? Every time they come in, are we telling them like the likelihood that they are going to survive the code? Are we telling them the risks of the code? Are we telling them holistically in their situation, what life's going to look like after the code? That we have full code as a default, I think there's a concern that these patients don't even have informed consent for that full code status because we have not, as a society, helped educate the public about what a code actually is, and specifically for their medical situation, the likelihood that they're actually going to benefit from it. In any other situation, a clinician can determine in their medical judgment, if something's going to harm a patient, they don't need to do it. A common example that's brought up is if a patient has acute liver failure, their LFTs are in the thousands, you're not going to give them Tylenol. So why is it then a patient's on max life support, they are on 100% oxygen on the ventilator, nitric oxide, they die of a hypoxic arrest, you can't reverse the underlying cause of the hypoxic arrest. They're on maximum life support. That code will not help that patient in that situation. And so why in a clinician's medical judgment, why aren't they allowed to treat the patient with their medical judgment? Why does some other full code status override that and override the physician in that? So I think that's the issue. The interesting part is how so many hospitals have had policies to allow physicians to say no to CPR for quite a while, but it's very variable. It's not just like a religious hospital versus not, because there are religious hospitals that have had unilateral DNR policies for quite a while. And so I think it's just like people aren't talking to one another enough, that all these hospitals are kind of doing their own little independent thing about whether they have a policy for, if it's truly medically futile, that the physician can say like no to this code being performed. Sometimes, and I think it's the way that physicians were trained as well. If you train at a facility where your superiors, they were showing you, doing unilateral DNRs, in your practice, wherever you go, you might continue that. Whereas if your institution, they did not allow that, then wherever you end up going, you're going to feel like that's not acceptable. So I think it's like a topic that we're not talking about enough. And I just feel like if we made it more public and transparent, I feel like we would as a society, go toward more unilateral DNR policies in cases of true medical futility, and in cases where we can actually like do a retrospective analysis to make sure that we're not doing like racial or ethnic differences, that we're not using it in ways that are like discriminatory to patients.
Yeah, I appreciate that. It feels like it's another one of the elephants in the room. Very much so, like some of the other topics that we've brought up recently. One of the other questions we have for you kind of relates to how we as a palliative care team try to address these things. So sometimes palliative care is consulted, sort of placing us in between a medical team that believes something is futile and a patient and a family who want everything, whatever that might mean. And so a couple of questions here. So how do you as a palliative care physician approach bridging that gap? And how do we advocate for our patients while not contributing to the burnout of our colleagues? Because don't we have some sort of a responsibility to our consulting teams, especially the critical care docs, to support them as well in all of this?
Yes, no, and that is a hard position to be in. And I think, our primary obligation is to the patient. We should not be allowing the patient to suffer because we are like too weak to talk with one another and like, do what is best for the patient. I think with the ICU team, sometimes, and I think we probably all see situations of this where, maybe it actually isn't medically futile. And like the clinician team, like they really think, oh, like we just hit the end of the road. But then as palliative care, we might not agree with that. We might see other situations where like it's a different attending and they wouldn't think it's the end of the road. So I think sometimes like, I know people have been a little bit upset with us when we as palliative care have actually gone to the ICU team and been like, actually the patient's preferences are to be full code right now. Mm-hmm. Like we recommend switching the code status back to full code because it's in line with their preferences. And it's still like, it meets like medical, like, reason to honor that. So I know the ICU teams probably don't like us for that one, but as palliative care, we're the patient's advocate. We hear where the patient's preferences are. We can help provide what the options are for care that are actually true options. And then we just help kind of align that. I think with the ICU teams, a lot of times we can just like kind of sit with them and hear them out. That can be very helpful. I think sometimes, and I find especially kind of like toward the end of a rotation, people like, I can see, like, I know these like clinicians very well and like their resident doctor as well. I can see when they're doing things different than what they normally do. And maybe it's just like they're tired, or maybe there's been like 3 traumatic deaths and they're like associating this next patient with those other traumatic deaths. And they're not the same. And I mean, I do this all the time. Like I am biased by the patients I've most recently seen. We all are. And I think just kind of as like an outside body to kind of talk about that, not in a non-judgmental, just we talk about it all as a group. Mm-hmm. I think something like that outside provider perspective can be really helpful. To kind of reevaluate all the medical facts. Once I get invested to a patient, I am very different than if I just look from that same case outside. Mm-hmm.
Yeah, I like that that point about helping to advocate for patients, but doing so within the limits of what is medically acceptable as well. Yeah.
And listening. Mm-hmm.
All right, Maureen, let me pass it over to you.
Thanks. Our third topic is how palliative care teams view the ethics of slow codes. We took a crude poll this week of palliative colleagues in our area here. With your background in both palliative care and ethics, and having published and worked in this area, how do you feel about slow codes? How has studying this changed your perspective? And how do you think palliative care providers in general view this topic?
Yes, and I think, there is data about how palliative care views unilateral DNRs. It really depends on clinician specialty. Mike Putman did a study a few years ago looking at by physician specialty, who's most likely to agree with a unilateral DNR. And like pulmonary critical care, they're like one of the top, palliative care is one of the top. And then other professions like cardiology, nephrology are toward the bottom at agreement with unilateral DNR. And I just think in practice, like looking at that data, it's like subjectively makes so much sense to me. And I feel like we just kind of maybe pick a profession based on kind of culturally, like our own independent values. And like, that's kind of where we end up. But I think many palliative care clinicians, I think, do think unilateral DNR, like slow codes are unethical to conduct, because it really isn't like trust like our primary thing that we need to develop with the patient. A slow code, so in our study, 85% of people that said like when slow codes happen, like we must tell the family about it. I cannot imagine in practice that that's what's happening. Why would you ever tell a family, I chose to like just do one chest compression on your loved one and then told, no, you would never do that. And so I think it's just like, from my perspective, I was glad to see how widely like variety of viewpoints clinicians have towards slow codes, and like in your analysis as well, the variety of viewpoints. The trust factor, like how can we break a patient's trust? I just think it's unbreakable. I think that's a hard line that we should not be doing. So in my opinion, I think if it's against our medical judgment to code the patient because we truly believe they're on max life support, they have a cause of cardiac arrest we cannot reverse, I think we need to be upfront with the family and tell them, I am so sorry. Your loved one cannot survive when their heart stops. We are going to help support them and keep them comfortable through it. And I know with us, when I've been involved with unilateral DNRs, the number of times that I have been told by patient families, thank you, when I tell them that, I've been out like really surprised by it. Because every time I do it, I do get a little bit nervous. I'm like, well, what if the family gets very upset? But the number of times that I get told, thank you, some of those families, they need us to take that decision away from them. Mm-hmm. And really, is there a decision even to be made? If we know in our medical judgment, they're not going to survive, there really should be no decision there. Why would we put our patient, through like battery by putting their body through something we know is not going to help them? Like so you can tell I have a perspective on this. I don't think that we should be doing it. And I also don't think that, as physicians, like we can walk in the room and say like, no to the code, but that nurse cannot. That nurse is at risk of losing like his or her medical license if they do not follow the physician's order. So I think it's for us as like physicians, we have to like stand up and be like, we don't need to just protect the patient, but we also need to protect the medical team from doing a medical procedure that is not going to help the patient and also put them at risk with like excessive moral distress leading to burnout, leading them to leave the ICUs, leading us to have like a shortage of caretakers for patients.
Yeah. And what you're speaking to is about sort of, one of the comments about the family saying thank you is you've removed sort of that burden of having for them to make the decision, right? And so they may feel like this is, they know where things are going, but they know that they should still be deciding. And so that autonomy being the next topic is at an all-time high at this point. Some providers do feel that patients have too much autonomy and dictating care. How do you see the balance of this paternalism and autonomy in society factoring into views on slow codes?
Yeah, I think as long as like in America, we provide a lot of intensive treatments to patients. As long as there is no scarcity, I think we see what the patient's preferences for care are, and we follow that. That is how we do things in America. We put people on dialysis that other countries never would put on dialysis. My viewpoint on it is there's truly no scarcity. We hear where the patient's at, and we do our best to help get them there. Even if they're like not waking up, they're minimally alert. Like, who am I to judge what their life is like? Who am I to judge what a meaningful survival is for them? Like, I shouldn't ever be judging their quality of life. They tell me what a quality of life is that is acceptable for them. And then we just, do our best with the options available to help get them to that point. I think when a scarcity exists, that's a totally different story. But right now, things are a lot different than they were, like last year. And this study was done before the COVID-19 pandemic. I really wonder, will the results change? Because a lot of institutions started implementing unilateral DNR policies during COVID-19. And would these results be totally different if we repeated the study?
I agree. I think that's really interesting. And then you kind of talked about this one already about the fifth topic about admitting to slow codes. I was very surprised at the number of clinicians that thought it was important to share with family that a slow code is being done, because I don't see how it would be coming out of somebody's mouth. We're just going to slow code. I just don't. In our team's experience, none of us can recall any provider ever admitting to the family that they did a slow code. Is that something you have witnessed? And how do providers approach that with the family if they're saying that they have?
Yes, I have never witnessed it either. I think, and this is where, a lot of the people that are strong proponents of the slow code are actually like neonatologist pediatricians. And I'm always like kind of surprised by that. It's very, I can see the viewpoint where, they are showing the families that like they're doing everything for their loved one. Mm-hmm. Now they don't understand that we're actually not doing everything for their loved one. We're doing it halfway. Mm-hmm. But like, attending critical care conferences before as well, there's a lot of belief that like families watching that code happen, that is a way of for the family to cope with that loved one's death. And like, I've been outstanded, like, that's an interesting way to look at it. And, you know, maybe it does help them cope with their loved one's death, that the doctors did everything. But we are lying to them. We didn't do everything. I think that part I can't get over. And to be honest, is that how we want them to cope with death? Or could we do something different? Could we say just, you know, this is not what a natural death looks like. This is what a natural death looks like, and just tell them what, you know, a true natural death looks like, and give them that other option. To be honest, I don't think we always explain to families, you know, that we can control their symptoms at the end of life. We can do things where we can like keep them on pressors, you know, do things to help, you know, keep their heart function going, like amiodarone. We can just do medicines, but if their heart naturally stops, we allow them to pass away. That middle ground there, where like you do everything up to the point of coding. And I think if we gave that middle ground more often, maybe we'd have a lot more people choosing DNR too.
I agree. Yeah. And that leads back to Marty again.
One last question before we open up the floodgates for commentary. Anything that you edited out of this paper that you think is worth mentioning now? Sometimes interesting things are discovered, but they just don't make it into the final publication.
I would say one interesting thing was the variety between the two institutions. So there's a lot of difference in autonomy between like resident doctors between the two institutions. And so one institution, it was very heavily attending dependent. The attending was the one requesting that slow code, not the patient, not the family, the attending's requesting it. And then the other institution, like the residents are really like doing all kind of like medical decision-making most of the time. The attendings are a little bit less present. So then like the resident doctor is the one making that decision. So I think that's kind of interesting too. You know, the attending doctors, like they do have a lot more experience. And I wonder like, you know, potentially like, are they saying no more often? Because that's what our study is showing. The attending doctors are the ones saying, don't code that patient. The resident doctors are more likely to be okay coding them. And then the nurses, the nurse practitioners, physician assistants, they're a lot more likely to say, let's do the slow code.
Gotcha. All right, let's open it up for some discussion. If you feel comfortable, just unmuting and ask your question. Patrick, I see you unmuted.
It's a bit of a comment, which is one of the things I sort of stumbled across, especially with people in a COVID ICU this last 24 months, has been to sort of say to people, there's kind of 4 parts to a code. There's mechanical ventilation, there's medications like pressors, there's the chest compressions, there's defibrillation. And I'll often explain to families, your family member's getting half of this already if they're on pressors and they're intubated. And we don't think that doing compressions is going to add anything to their surviving. And if you guys all kind of know this, but I've had a lot of families sort of stop and say, they're already kind of having half a code already. And I'll say, yeah, essentially for the last week or two. And that has often been a critical moment for them to realize the magnitude of the illness and the treatment burden somebody's got already. And rarely have people say, well, I still want them to have chest compressions on top of all of that. It's helping, you know, to deconstruct what it is we do during a code and help them understand a lot of that's happening already. And I've just found that to be really helpful. The other thing I'll just about, you know, I've had families ask about, can you kind of do like a soft code or kind of half a code? And I worry that that gets at that trust issue about, and what my response, I'm in a rural hospital now in central Minnesota. My response is no. If you want your loved one coded, they're going to get the whole code. We don't do anything half-assed here in our hospital, and they're going to get the full code if that's what you want. And often that makes people stop and realize, so we play for keeps if you want to try to bring them back. And I think that often helps families realize that that's not an option. I'm trying to sort of signal that, because I don't want them to think we did half of a surgery or something else with other care someone may need. So that's gone over pretty well with people. Just like, no, we don't do it. It's like doing half a heart cath. We don't do that.
Right. Thanks, Patrick.
Jocelyn, I saw your hand raised.
Yeah, so I'm Jocelyn. I'm a nurse practitioner with Palliative Care at St. Luke's, but up until August of last year, I was actually a critical care nurse practitioner. So I have the pleasure, I guess, of seeing both sides of this. And when Marty asked me this yesterday, I paused for a while because I'm like, I have feelings and thoughts. But really, I was racking my brain to think of a time where I've actually legitimately done this, and I couldn't think of it. And I think the reason is exactly as you said, is I worked with a lot of strong ICU attendings, strong ICU physicians. I particularly have Eric Siegel in my mind, who says, absolutely not. And the thing is, if you have the time to make that assessment, you have the time to call the family and talk to them about that typically. So that was it for a lot of us, is if we saw this going down and it wasn't going to be good, someone's in the room and someone's on the phone. And that phone call is direct, it's honest, it's, you know, brutal at times as it should be, because it's like, this is what's happening, this is what we can do, and this is why we're going to put a limit on it. And really talking to them about that. And that's where, like, I find it unethical if you just don't have that conversation, or if you have that conversation and you've offered it and then you don't do what you've told them you're going to do. But if you have that conversation and unilaterally you're saying, exactly, this is going to provide more harm than benefit, I think that that's really the best way to go if you have that opportunity to do it. That's all.
I agree with you.
Any other thoughts or questions, guys?
I just have one more thought. I think the moral distress from the nursing perspective is something that you know, mentioned and discussed as well. Having been that nurse who has been on the chest of a frail 79-year-old woman and broken ribs as I've done CPR, I think the medical futility and the discussion about that before it happens is so important. And like Jesslyn just said, if there is time to have, you know, to have that discussion, it is so important to do that and to be clear and direct, and not to say, what do you want us to do, rather than this is what we're going to do because of those reasons. And I think that was well said, Jesslyn.
Yeah, and I think one thing I wanted to point out with that too, you know, who had the least moral distress about doing chest compressions is that attending physician. Who has the most? The nurse and the medical resident who's doing the CPR in practice. I shouldn't say the attendings don't do it, but when medical residents and nurses are there, I think they're going to be the ones most likely doing it. So, you know, maybe like with these decisions too, like, you know, maybe people have less moral distress because they chose that profession and they can just handle it better.
Mm-hmm.
Or, you know, maybe like people who are a little bit further removed from it, that's also why they have less moral distress. It's not that the situation's not distressing, they just aren't always there for it.
Jacob?
Well, while we're talking, I'm Jake, I'm a chaplain on the palliative care team. And while we're talking about moral distress, I was struck by the religious, spiritual categories that were listed. And I was fascinated that the majority were none. And I found that more often than not, we are all influenced by the culture around us. And so I'm thinking about the culture of Chicagoland area, the Midwest, and I would be fascinated to know if this study might be different if it's played out in a different cultural context, whether it's on the East Coast, the West Coast, but also how many of those nuns have been informed by a spiritual background as well that impedes or impacts their moral distress.
Mm-hmm. I think that is a great point. And I was really like, the reason we chose to include spirituality, religion here was I was hoping that there would be a difference in outcomes, and we didn't find that. And maybe we were just underpowered to do it. But I think it's a strong hypothesis that, you know, independent like clinicians, spiritual or religious beliefs impact how they view slow codes in practice. Yeah, we just weren't able to find it with ours, but I think that'd be a great study for the future.
Marty and all, I just want to say as usual, thank you. And Gina, thank you so much. I'm Jerry Wilmus. I'm a long-standing hospice and palliative medicine physician in Missouri. And I think I don't have a question so much as just to kind of give affirmation, if you will, to what you've all said. I think first and foremost, I want to say to Jesslyn two things. Good for you that you never had to be part of a slow code. And I agree completely that that's the key, is to have strong communication and strong teams, because as you said, Gina, we need to be advocates for patients. And so I think all the comments help reinforce and myself in terms of how do we continue to be at the right place and have the right communications as always with our patients. Not easy to do, obviously, but thank you.
All right. Thank you so much, Gina. This was lovely.
Of course,
Gina.
thanks for having me. Nice to meet you all.
Absolutely. Come back anytime.
Thank you.
Have a good weekend, everybody.
Bye now.
Bye.
Thanks.